Dengue fever is caused by dengue virus, and dengue virus has four serotypes, and its mode of transmission is bite of female mosquito Aedes aegypti, and Aedes albicans can create this condition. Is as we know that it is viral infection, and there are certain clinical features of this fever, like symptoms usually last for 2 to 7 days with high grade fever, abrupt onset, continuous in pattern. So you have to differentiate between the fever. Fever may be caused by predominantly malaria, or there may be typhoid fever, and there may be dengue fever. So how can you differentiate? Yes, only because of clinical features you can differentiate. In dengue fever, there is severe headache with periorbital pain, which is probably not present in other types of the fever, like in fever of typhoid. In muscle pain and joint pain and myalgia is most commonly present in dengue fever. Rashes are present only in dengue fever, while in malaria no rashes are found. Dengue hemorrhagic fever with dengue shock syndrome. It is only the most specific character of the dengue, and hemorrhage occurs like from GI bleeding, epistaxis, hematuria, severe abdominal pain, persistent vomiting, febrile seizure may develop. So, if it is untreated, hemorrhagic fever may progress to shock. Because of hemorrhage, shock develops, and then pallor, tachycardia, tachycardia, decreased level of consciousness occur, and dreadful conditions can develop. So, the diagnosis for the dengue virus is serology of IgG and IgM. In later stage in diagnosis, we can diagnose, and the management. And the management for the dengue is supportive and symptomatic management, like antipyretics, paracetamol should be given, IV fluid should be given, platelet transfusion is needed for if bleeding is developed, and also we have to maintain hypoglycemia of the patient. Prevention of the dengue is by wearing long cloths, insect repellent application, mosquito nets, and improve water storage practices can prevent dengue fever. So in this way we can manage and prevent occurrence of the dengue. Okay, so the topic is tetanus. Tetanus is defined as acute spastic paralytic disease, and its causative agent is Clostridium tetani, or spore forming bacteria. The mode of transmission of tetanus is spores present in dust, soil, which gets into body from broken skin through trauma or in tear lacerations. These spores get entry into the body and start dividing in anaerobic condition, and then tetanus develops with its clinical features. So what are the clinical features of tetanus? Are locked jaw, means jaw will be locked and the patient will be unable to move its jaw and the mouth. As you can see the typical picture in this patient, this condition is known as locked jaw. Rhesus sardonicus, which is grinding expression, and grinding expression as you can see in this patient, and because of spasm of facial muscle occurs. So this spasm will create the condition of rhesus sardonicus and grinding expression. With opisthotonus means spasm of the muscle causing backward aching of the neck of the spine. As you can see, this is typical opisthotonus position in which there is arching of a patient because of muscle constriction occurs, and this is typical picture of opisthotonus position which is caused by tetanus. Then drooling, fever, swallowing difficulty, and convulsions develop because of tetanus. These are typical clinical findings of tetanus. So diagnosis will be based on clinical examination. The patient will show this lockjaw condition, then the opisthotonus will be there, and by clinical examination, a clinician will diagnose the condition of tetanus. And differential diagnosis for this disease may be tetany or carpopedal spasm, because but no trismus will be there, and calcium level will be low in the serum, so we can keep it as differential. Bacterial meningitis can be there, encephalitis and strychnine poisoning can be put into differentials for tetanus. So The management for tetanus is supportive management, specific management, and preventive measures can be taken. Supportive management is good nursing care, keep patient in dark room with minimal voice, give fluids, rehydrate the patient, give oxygen and suction the patient from mouth and nose in order to prevent gas exchange, and specific management are give anticonvulsants for diazepam, and human tetanus immunoglobulins should be given. When a patient gets trauma, then that patient must be given ATA's drug through muscular route in order to prevent occurrence of tetanus, and penicillin G can be given for 10 to 14 days once tetanus is developed. So in this way we can manage tetanus, and preventive measures are diphtheria, DPT, tetanus pertussis, and immunization should be given with the tetanus prevention following an injury. In unimmunized patient, give ATAs muscular, and in fully immunized patient, single dose of tetanus toxin should be given. So in this way, we can manage the tetanus and save the life of patient. Okay, so another topic is poliomyelitis, and it is defined as acute viral infection of anterior horn of motor neurons, and that condition causes paralysis, encephalitis, and death. So this is dreadful and very dangerous condition, because once a person develops polio, becomes paralyzed for the whole life, and it is lifelong disease which causes a lot of problems in the patient. And the causative agent of polio are RNA virus, has three serotypes: serotype 1, 2, 3, which are responsible for the disease, and type 1 serotype is most common, accounting for 85% of the paralytic illnesses. Infections does not Infections with one type does not protect from the other, and the mode of transmission of polio is fecal-oral route. And the pathogenesis of this condition is virus infect the person through GI tract, and in GI tract it multiplies and then drains into cervical and mesenteric lymph node via bloodstream. Then 5% of infected patient becomes selective nervous system involvement, and viremia develops. Then what happens? That viremia, virus particles are neutralized, and then no clinical illness occurs. If antibody fails to neutralize the virus, virus proliferates and invades the body with destruction of motor neurons, and anterior horn cell destruction occurs, and destruction of brain stem and spinal cord occurs. So once the destruction of brain and spinal cords occur, then the paralysis starts, and a big person becomes paralyzed with the passage of time. So the clinical features for this disease, polio, is, as first of all, a patient becomes asymptomatic, then abortive poliomyelitis develops, then non-paralytic poliomyelitis, when another is paralytic poliomyelitis occurs. In paralytic poliomyelitis, acute flaccid paralysis with weakness, which is asymmetrical weakness of lower limbs, affects the body more than upper limbs. Means lower limb of a person becomes affected more as compared to upper limbs. So, polio typically affects lower limb, and asymmetrical paralysis occurs in polio. What differential diagnosis we can keep for polio is fever, and fever occurs in. We can keep differentials like poliomyelitis, Guillain-Barré syndrome, and transverse myelitis. These all three diseases can be kept as differentials for polio. Fever is present in polio Paralysis is asymmetrical. Cranial nerves involved bulbar and bulbospinal variants are affected. Bowel and bladder function is absent. CSF shows lymphocytic piliocytosis are normal or increased protein. So, the diagnosis for polio is virus isolation, then stool sampling should be done, and confirmatory test is CSF routine examination. Virus isolation is confirmatory test, then CSF examination will show increased protein in the CSF. Management for poliomyelitis is hospitalize the patient, bed rest the patient, prevent muscle fatigueness with minimum handling of affected part, maintain limbs in neutral position, give analgesics, antipyretics, maintain nutrition of the patient, hydrate the patient, avoid constipation and bladder care must be kept, keep airway patent by suction and watch the respiratory distress and monitor it and give physiotherapy for the patient after acute stage is over. So in this way we can treat the patient, but management is the most important aspect for polio, especially if by injectable polio vaccines and oral polio vaccine should be given, and 3 doses of series oral polio vaccine should be given, and these 3 doses are lifelong immunity for the polio. So in this way we can manage this dreadful and dangerous condition of the polio. It is a asymmetrical paralysis occurs with motor neuron destruction and anterior horns are affected, and paralysis of the body occurs with lower limb paralysis. So we can manage the patient, but the most important thing is prevention by oral polio vaccine and injectable polio vaccine immunity. Fever of unknown origin are also known as pyrexia of unknown origin. So it is fever which has no non-definitive cause in children with fever greater than 38 centigrade centigrade and 101 Fahrenheit at least for 8 days duration is fever of unknown origin. There is old definition of the fever of unknown origin is children with fever greater than 38 centigrade for 3 weeks in whom no diagnosis is apparent after initial outpatient of the patient. So that is known as fever of unknown origin. Causes of this fever are infectious and non-infectious causes. Infectious causes are bacterial, viral, other causes. In bacterial causes, TB can be there, brucellosis, osteomyelitis, and salmonella can be there. In viral causes are cytomegalovirus, Epstein-Barr virus, infectious mononucleosis, and the infectious causes are malaria, Q fever, histoplasmosis, and cryptosporidiosis. These are the infectious causes. Non-infectious causes are oncological causes like leukemia, lymphoma, neuroblastoma. Autoimmune causes are SLE, IBD, and polyarteritis nodosa, and other non-infectious causes are dengue fever, infectious fever, and pancreatitis. So these are the causes of a pyrexia of unknown. So the treatment for pyrexia of unknown will be antipyretic should be given, and rehydration of the patient should be maintained. Patient should be rehydrated with prevention of hypoglycemia and hypothermia. So in this way we can primarily manage the patient and prevent the fever occurrence of the patient.